So we're going to get started. We're waiting for the dean. Hi, Jeff.
Oh, sorry.
So we're going to get started. On behalf of the search committee, I present to you Ms. Mercedes Hernandez. We met at CSWE, and I'm sure you brought us some warmth from California. She's from the University of Southern California, and her talk is titled Cultural and Protective Factors Are Critical to Outcomes Among Latino Families Living with Schizophrenia. So you're on.
Thank you. Thank you, everyone. Thank you for being here today. It's nice to see some familiar faces from this morning. The title of my presentation, as Dr. Amer mentioned, is Cultural and Protective Factors Are Critical to Outcomes Among Latino Families Dealing with Schizophrenia.
The IT people are right out the door.
You can touch the board also. Ms. Hernandez, you can also touch the board maybe. That arrow will change it.
My hero.
The keyboard is over there.
There you go. You can do it quite fast.
Johnny can go.
All right, so I'll begin my presentation by sharing a little bit about my background and how my research experience has been influenced by my practice experience. And then I'll go into two projects, one based on my qualifying exam, which is looking at hope and burden among Latino family caregivers of individuals with schizophrenia. And then I'll talk about my dissertation project and how this was influenced by this hope and burden study. And lastly, I'll be talking about my research agenda and talking a little bit about where I see myself going in the future in terms of my work. So my research interests are in mental health services research, but specifically looking at serious mental illness among Latinos. And my interest in this population comes from my own background. I'm Latina, Mexican-American, was born in LA. My family are first-generation immigrants. And growing up, I witnessed a lot of the challenges that they experienced as new immigrants. And I wanted to learn what I can do to help mitigate these challenges and these difficulties that they experienced. So I went to college. I was the first of my family to graduate. I majored in sociology and Chicano studies. And during this time, I also had opportunities to do volunteer work. And all of this influenced my decision to go into social work. And after I obtained my MSW program, my MSW degree and finished my program, I went into working as a psychiatric social worker with the LA County Department of Mental Health and one of their directly operated mental health clinics serving individuals with serious mental illness. Now, the clinic was located in South Central LA in the city of Compton, and historically this area has been African American, but now there's been a demographic shift where now the majority are Latino. And I was the only Spanish-speaking clinician at this clinic, which meant that I saw all the monolingual Spanish-speaking clients. And this was difficult for them because they had to wait a long time to be seen. And this was particularly the case for the initial appointment, initial assessment. So there was an average of 2 months for them to be seen. And so what I was always surprised about was how many of these clients would come in after having waited for 2 months. And what I saw was that many of them would come in with their families. So it made me just wonder what resources do these families have that can help to support these clients. And so I was curious about that. And after working with the LA County Department of Mental Health for 6 years, I began working with the LA Unified School District as a psychiatric social worker at one of their community mental health clinics in the South Central LA area. And a lot of the issues of access and quality of care were present in this setting as well, and that there was also a long wait for them to be seen. I was also the only Spanish-speaking clinician at this site. And a lot of the issues of also of quality of treatment were present here, and that the treatment options that were available oftentimes to the students and to the clients that we saw were not really addressing their needs in terms of them coming from an urban, often very violent setting. So all of this influenced my decision to pursue a doctoral education, and this is the 5th year in my program, and during this time I've had the opportunity to gain knowledge and skills that have begun to help me to look at these issues of access and quality of care more critically. To share a little bit about one of the families that I worked with when I was working with the LA County Department of Mental Health. I was seeing a client who had recently been discharged from the hospital, and after having had his first psychotic break. And he would come in with his mother, who was very interested in learning what she could do to help her son. And so we worked together for some time, and during our work together, I found out that she was also a client at another one of our outpatient clinics for her own diagnosis of schizophrenia. But despite the challenges that she experienced as a client, she was stable at the time, but she was very willing and very interested in learning how she can support her son. And when she wasn't available, her husband, the client's father, would come in and also accompany the client to these appointments. We found out later that his sister was also showing some signs of the illness. So even though this family may fall in the extreme range in terms of having different clients within the family, as well as individuals performing the role of caregivers and being clients, it is a real case from my clinical experience, and I've seen that this is important, and it has been something that I've seen in terms of me being able to share this with students. I saw this in my participation in an assessment and diagnosis course, as well in teaching a social work research methods course. So I believe that these experiences have informed my teaching, as well as the experiences that I had as a facilitator for groups that I conducted, developing treatment plans and seminars. All of this has informed my teaching, and these skills have transferred into the classroom setting. Okay, so I've worked with my primary faculty mentor, Dr. Concha Barrio, from the beginning of my program. And the opportunities that I've had with her have been wonderful. I was one of the interventionists in her intervention development project, which these two studies are looking at, and I'll talk about these a little bit more. But I've also had an opportunity to work with other faculty within our serious mental illness cluster, which is led by Dr. John Brecky. For instance, I've worked with Dr. Anne-Marie Amada on a project looking at the integration of spirituality into the County Department of Mental Health. And this is of interest to me, given that Latinos utilize this resource a lot, so it's something that I've learned a lot from. I also had the opportunity to work with Dr. Maria Aranda on her NIMH-funded depression study with Latino older adults. And this was of interest to me because she was able to adapt an intervention to work with this population and able to integrate it into a community health setting. So I've learned a lot from these experiences. But today I'll be focusing on these two projects. The first, again, is looking at hope and burden among Latino family caregivers, and it's based on my qualifying exam. And then the second is my dissertation, which was influenced by this study. Hope and Burden Among Latino Families of Adults with Schizophrenia was published last year in the Family Process Journal, and it is using data from Dr. Barrio's intervention development study. Families play an important role in the lives of individuals with schizophrenia, Given that the illness usually begins in late adolescence or early adulthood, families are highly involved in providing care and support to clients. And unfortunately, this was not always the case in terms of supporting families. In the past, families were falsely blamed and seen as causing the illness. We know now that that is not the case. Research has shown that this isn't true, and that family support can actually help to improve outcomes and help to benefit clients. And so family support and family involvement can be seen as to complement the treatment and seen as a form of treatment for clients. And this is the case for all family systems, but particularly when we look at low acculturated Latino families, we find that clients tend to live with their family more so when compared to other groups. And so therefore it's important for us to learn more about how we can support these families and learn more about what cultural processes and factors may be involved and how we can support these. HOPE is a resource that is used by caregivers, not only those caring for someone with serious mental illness, but also other health conditions as well. A multicultural community study that included low acculturated Latinos, Euro-Americans, and African Americans found that Latino caregivers tended to have very high levels of hope when compared to these two other groups. And so we wanted to look at how we can, how this resource helps these families address their caregiving issues that may be presented. Because caring for a family member with serious mental illness with schizophrenia can be challenging, and it can result in burden. And burden is seen as the challenges that these families may face in their caregiving responsibilities. And it is typically conceptualized as comprising objective and subjective components, where objective components have to do more with the concrete factors, such as financial challenges that they may face, or challenges that they may face as a result of the behaviors that clients may exhibit as a result of the illness. Whereas a subjective burden has to do more with the perceptions of these challenges that families may have, as well as the emotional reactions that they may have as a result of their caregiving. It's important also to consider that with Latino families, especially low acculturated families, they may have additional challenges due to their low socioeconomic status, their low English proficiency, which may all impact their ability to access care for clients. So in this study, we're interested in looking at this relationship of hope and burden, and we hypothesized that hope would be associated with a decrease in burden. We used the complete baseline data from the psychoeducation intervention, which is comprised of a community-based sample of Latino adults with schizophrenia and their family members, and we found that the majority of clients lived with their family. The majority of clients were male, whereas the majority of family members were female. We found that most family members were married, most clients had never been married, and most clients were U.S. born, whereas most family members were born in Mexico. To examine burden, we used the family burden interview scale, and we looked at the objective items in this scale. To examine hope, we used the Hope for the Future scale, and we were also interested in looking at how symptomatology may influence burden for caregivers. So we used the PANSS measure, the Positive and Negative Syndrome Scale, and we also examined or included length of illness in the model. We conducted bivariate analyses to examine some of the relationships, and we found that symptomatology, that PANSS did not influence burden, so then we dropped that from our model, and we included the other variables. And we used this hierarchical linear regression, this analysis method, because we were interested in examining the individual variability that each variable contributed to burden. And so we entered length of illness first and allow that to capture most of the variability in the model, and then followed by hope. And hope had a larger estimate. Symptoms were in the mild range for clients, and this makes sense given that clients were receiving outpatient care. We found that burden was low for family members, and that on average, family members reported high levels of hope. And these last 2 points are similar to other studies that have included low acculturated families. On average, clients had 13 years of illness. We found a negative relationship between length of illness and burden. So as length of illness increased, burden decreased. We also found a negative relationship between hope and burden. And overall, our results indicated the length of illness and hope predicted burden. And so about a quarter of the variability of burden came from length of illness and hope. And most of this, 19% of it came from hope. So hope was a stronger predictor. So our findings indicate that hope is associated with a decrease in burden beyond length of illness. So some implications for this are that although families reported low levels of burden, it's important for us to not assume that burden isn't present within these family systems, because there may be other challenges that these families are experiencing, and perhaps other cultural factors that may influence how they manifest their caregiving responsibilities. It's important for providers to be aware of the role of hope within these family systems and foster its use when working with them. And one of our recommendations was that future studies consider qualitative methods when examining hope and burden. And along these lines, I was interested in looking how qualitative methods can inform burden and hope, and so that influenced my decision for my dissertation study to be a mixed methods study. So CIFIMA, this stands for Culturally Based Family Intervention for Mexican Americans, and I'll talk about that a little bit more later on. But I was one of the interventionists in this intervention, so I was able to see how families, how they grew from participating in the intervention. And now that I've gone back to see these families, I've had an opportunity to see how what they've learned has continued to help them in their caregiving. And also my participation in the Hope and Burden study, that was also important in that it helped me to see how hope can be a potential protective factor for these families. And then I also assisted in conducting a mixed effects analysis, where we were interested in looking at how the intervention impacted outcomes. And we found that burden decreased over time for those in the intervention, and the knowledge of the illness improved or increased. So my experience and participation in these projects helped to influence my dissertation work, where I'm looking at how protective factors can contribute to outcomes for family members as well as clients. And as I mentioned earlier, I conducted a sequential mixed method study. So I used a mixed method approach where I analyzed existing quantitative data and followed by the collection of qualitative data. Okay, this leads me to my dissertation, which is titled The Role of Protective Factors and Outcomes for Latinos with Schizophrenia, and it was funded by NIMH. Family psychoeducation is an evidence-based treatment for clients and for families. This has been found to be the case in a number of studies that have been conducted here in the U.S. as well as internationally. And a recent review published a couple of years ago found that differences in outcomes tend to be influenced by the length of treatment as well as the modality of psychoeducation model that is used. So. But what is common across these studies is that the focus has been on relapse. and as the first line of treatment, and it should be in a way, because we know that with continued hospitalizations, recovery it can take longer for an individual to recover. But what I wanted to look at a little bit more was get the perspective of clients and families regarding what they consider to be components of success and well-being. So I wanted to get their perspective. Models that have included protective components and cultural factors have been found to benefit local traded Latino families in terms of outcomes for clients. And there aren't many studies that have included this population. I found 3 RCTs that have included local traded Latino families. But again, those that have incorporated cultural components and protective factors have been shown to be related to positive outcomes for clients. Protective factors can be seen to function as resources that help to alter negative outcomes. And moreover, the concept of resilience extends beyond protective factors and looks at the processes involved in successful adaptation to stressors. So it's important to consider that protective factors and resilience aren't necessarily something that's innate within an individual, but that it can be fostered within a family system. In the same way that the whole family can be affected by having a family member with schizophrenia, it's important to consider how the whole family can come together and help to mediate recovery for clients. So along these lines, I want to direct your attention to this quote from the report of the Surgeon General. The attention given to Latinos' possible strengths is an important contribution to the study of Latino mental health. Strengths are protective factors against distress and disorder and can be used to develop interventions to prevent disorders and to promote well-being. So this speaks to my interest in being able to help look at what is healthy within a family system and look to incorporate that into treatment models. So the intervention, SIFIMA, is rooted in the evidence-based elements of multifamily group psychoeducation, but in addition, it includes adaptations for this population. It takes into consideration their caregiving ideology, as well as it being congruent with their linguistic and cultural needs. So the intervention was informed by this heuristic model, and it was based on ethnographic work conducted by Dr. Barrio, as well as cultural exchange theory and strengths-based perspective. And it can be seen as a conceptual framework as well as a method, in that we are continuing to incorporate findings and feedback from the intervention back into, or the feedback from participants back into the intervention. So it's utilizing an iterative process. The intervention can be pictured as an exchange of information between the Latino family and the provider system, and it is in this bidirectional exchange of knowledge, attitudes, and practices that change within the family system can take place. And although it's depicted here in 3 stages, they're very much influence each other and are fluid. In the beginning, we are seeking to gain more information, more knowledge from the families in terms of what their conceptual frameworks are, what their explanatory models are, so what they perceive to be the cause of the illness. And this helps to inform us and be able to accommodate our treatment to meet their needs, all with the goal of being able to have a stronger integration, so that the intervention that we're providing, the knowledge that we're providing them with, better meets their needs. So my aims were to examine the effects of protective factors and outcomes for both clients and families, and also to explore protective factors a little bit more and get more idea of what their perceptions are regarding outcomes. So I used a mixed method approach, And I examined existing quantitative data, which consisted of 64 dyads, which were 64 clients and 64 family members. And then based on these findings, I then went back to those who participated in the intervention. So I interviewed 20 families, 20 clients, and 20 family members. So protective factors that I examined were hope. I also looked at warmth and criticism, which are components of expressed emotion. And I also looked at adaptability and cohesion, which are using the phases 2 measure. For outcomes, for family members, I looked at burden as well as knowledge of the illness. And for clients, looked at quality of life and symptomatology. In terms of comparing the family members on treatment condition, we found no differences. The majority of family members were mothers, although we had some participation from fathers as well as spouses. And we did find some differences by treatment condition for clients, and that most clients in the intervention were younger and therefore had a shorter length of illness. And so given these differences, I was able to control for these 2 variables in my analyses. Analyses consisted of path models followed by mediation analyses. So longitudinal analyses that include cross-like models, it allowed me to be able to examine my 2 variables of interest, which were protective factors and outcomes simultaneously, and look at how they were able to change over time, and look at how the protective factors influenced outcomes. By including protective factors as mediators, I was able to examine the potential influence that they can have on outcomes and see how the intervention, by influencing these protective factors, may indirectly influence outcomes. So results for family members, we found that hope and adaptability and cohesion contributed to a decrease in burden, as well as several burden subscales. And this was objective burden. For family members, we also found that perceptions of criticism decreased for those in the intervention, and there was also a trend for increase in family warmth. And for clients, we found that hope contributed to an increase in several quality of life subscales. And similar to family members, we found that perceptions of warmth increased and that perceptions of criticism decreased. And we found there to be an indirect effect for 2 quality of life subscales, the intrapsychic and instrumental. And intrapsychic quality of life, it includes items such as curiosity, motivation, and instrumental items have to do more with social roles that individuals take, as well as their perceptions of these roles, how they're functioning in these roles. So the intervention contributed to a decrease in criticism, which then contributed to improved intrapsychic and instrumental components of quality of life. We also found there to be an indirect effect for general psychopathology, subscale, and warmth. And general psychopathology is a subscale of the PANSS measure, and it's examining items such as depression, anxiety, somatic complaints. So the intervention led to an increase in warmth, which then contributed to a decrease in general psychopathology. So after conducting the quantitative analyses, this helped to inform some additional questions that I would be asking when I went back to interview these families for the qualitative portion of the study. And I'm currently working on analyzing the qualitative data, but what I will be doing is developing categories and themes to address those questions that I included in the interview guide, as well as those themes that were generated just from the interview process itself. But given that I conducted all the interviews, I'm aware of the most salient themes. And what I've uncovered is that hope is tied to family member and client religious and spiritual beliefs. Now, hope was one of the protective factors that I asked about in the beginning, and families and clients very quickly were able to tie it to their religious and spiritual beliefs. So religion and spirituality is a strong source of support for these families and clients. And I also found there to be strong feelings regarding medication, in that they understood that it was something that was necessary for their well-being, for their treatment, and yet they were concerned with the long-term effects of taking medication. And this was particularly the case for those clients who were taking additional medications due to other health issues. I also found that families tended to have a holistic view of illness and treatment. And by holistic, I mean that they understood that medication was important, but they also believed that their religion and spirituality was an important source of support, that their family was an important source of support, that eating well, exercising, all of this contributed to their well-being. I also found that clients who had substance abuse issues had family members who expressed a lot of burden. And these were also the clients who had several hospitalizations since the intervention. Clients overall, though, expressed improved relationship with their family as a result of their family members' participation in the intervention. So they talked about how much they appreciated having their family member participate in these 16-week-long intervention. It showed that they cared. It resulted in their family member understanding their illness better, and this contributed to a better family environment and helped to improve relationships. So these are two quotes from family members. The first is from my mother. Before we had a lot of pressure and sadness. We all attacked him. We would put much pressure on him. But now since the group, we are better. And the second is from a daughter. I no longer get depressed. From the meetings, I am seeing that everything we learned, patience, love, medicine, I am putting these into practice, and the change in her makes me feel happy. So some preliminary implications, some preliminary thoughts that I'm having on these findings are that although there was little change in level of hope and adaptability and cohesion, so these two protective factors pretty much remained stable throughout the assessment points. The interviews showed me that families and clients did improve on their hope and family relations. So they talked about how they benefited from participating. And also, we're finding that there are promising results in terms of hope and expressed emotion as contributors to improved outcome. So expressed emotion may be addressing specific behaviors which may be more modifiable through the intervention. It may be that the intervention is effective at providing knowledge, which then helps to, in terms of changing the expressed emotion behavior. So expressed emotion may be addressing specific behaviors, while hope and adaptability and cohesion, these protective factors, may be addressing cultural values that are already very strong within these family systems. Nevertheless, the families talked about how much they appreciated having these components be a part of the intervention. They felt that it spoke to their beliefs, so it made for a better environment. So as in any study, there are limitations. Given that the intervention is in the development phase, the sample size is modest, and this may influence power for quantitative analysis. However, by collecting additional data, we were, from a subset of participants, we were able to triangulate our findings, and this has been helpful in cross-validating our results. And one of the things that I'm interested in looking at a little bit more is the role of knowledge of the illness and how it can itself be a protective factor. I've been looking at it as an outcome, and it clearly was an outcome because we did see an improvement and an increase in knowledge of the illness. But families and clients talked about it as a mediator and how it helped them be able to understand the client more and how the clients felt understood, and how all of this contributed to a better family environment and better family relationships. And we will be integrating findings to further refine the intervention and support those components that contributed to improved outcomes. So it's going back to the interventions heuristic model and its iterative approach, and then we're continuing to incorporate feedback back into the intervention. Okay, at this time, my focus is on my dissertation. However, there are various other manuscripts that I will be working on, and they're in different stages of development. And I want to continue in this line of research and examining protective factors as a way to help understand these family systems more and help to mitigate some of the disparities that this population experiences. I'm interested in seeking funding, such as a Career Development Award or a smaller RO3. And I'm also looking into other sources of support, such as the Robert Wood Johnson Foundation's New Connections program, which supports early investigators from underrepresented groups by providing mentorship as well as grant support. I want to thank you, and I welcome any questions or comments that you may have.
Thank you for the presentation. It was very interesting. You found a relationship between hope and clients and caregivers, religion and spirituality. I'm wondering if you're also in your qualitative themes finding a relationship between burden and clients' religion and spirituality, issues around the illness being a test or a cross that they're bearing from, say, God, or a punishment that they're experiencing from God, say, for a particular behavior of theirs.
So then looking at as their caregiving challenge that they've experienced as a result of, or they're explaining this in terms of their religion and spirituality.
Yeah, interpreting burden through the lens of religion and spirituality as they're interpreting hope through religion and spirituality.
In a way, I can see that they saw the way they expressed themselves about their whole religion and spirituality. I think it was more of a positive thing. But there were some families who initially, I remember from the group, would talk about how maybe they had done something wrong and maybe this was a punishment from God, the illness. So there were some families who expressed that in the beginning, not so much at the end of the intervention. I've gone back to visit these families, and they don't. It's not something negative. They see it as more as a positive thing. Yes.
Thank you for your presentation.
Thank you.
Wonderful job. So it seems like you want to move forward to continue to look at these protective factors and the roles that they play. Are you kind of thinking about, I wonder what your thinking is in terms of the intervention work? Are you hoping to also continue to do that sort of work, or?
Yes.
Or yeah.
Yes, that would be something I would be interested in continuing. Yes, and being able to incorporate protective factors into the intervention. Yes.
Might ask you, if I may, a slightly different kind of question. You seem to, in your life and career, to be happily settled in California, where you've just gotten your 3 degrees, and I presume where a number of your family live. What are your thoughts about coming across continent, if you were offered a position at Hunter, to resettle in New York?
Well, I see it as something as exciting. I would be very much be interested in looking at the opportunities that are available in New York with other researchers, investigators who are working in this line of research. I also see that this is there's a large Latino population, which is my population of interest. So that's another fit for me. But I do understand that I've been living in California all my life, and it would be a big change. But I'm willing to make that change. Yes.
One of your colleagues, Maria Aranda, and one of your faculty members, Karen Lincoln, lectured me at length when I gave a presentation about the the dual nature of religiosity, that if I'm strongly religious and spiritual, and I feel that I'm not given anything that I couldn't handle, and yet I'm not handling it, then somehow I'm not living up to the expectations of what I should be as a religious being. And I was wondering, in your working with this as a construct, did you sense any of that double bind for some of the caregivers where, from a religious spiritual purpose, they should be able to manage better than what they are, and they were conflicted by feeling they were failing at their caregiving?
Yes, I do remember some families talking about that and how challenging it was for some of them. And I think particularly for those whose family members who's with the illness or experiencing more challenges, like I mentioned, I think related to substance abuse, that was a big concern, and those were the families who were the most challenged. And but yeah, no, I do hear what you're saying in terms of this kind of bind that they may find themselves in.
Hey, it's a great talk, thanks. And I was wondering what your plans would be for collecting new data, because I really appreciate how you're studying protective factors, because you don't really find them in most data sets. And even when you look at interventions, they often appear to not be working, because it seems like people who use interventions need them more. So then you find people with a greater severity of illness using the interventions, and then it looks like they're actually not working, because they're sicker to begin with, so they end up in hospitals more frequently, for example. So it seems like it'd be a great area for collecting new data, on these protective factors and on interventions that can get around some of that artifact that, it would appear, if you look at these initial existing data sets, that they're not working, because you get people who have greater illness.
Well, I was very fortunate in that this data did include, protective factors, did include these variables. And yes, it would be something that I would be interested in incorporating into my work, so it would be something that I would want to very much to collect. Yeah, so I would be, I'm very willing to look at this further. Yeah. Yes.
So I really appreciate your talk, and it's a really a different way of thinking about this issue. And I'm wondering, how do you see yourself infusing? I know you alluded to that in the beginning in terms of teaching, but how do you see yourself infusing your research into your teaching? And embedded in my question is that I find students push back a bit when they hear the construct of religiosity. If they hear spirituality, they tend to be a little bit more settled. That's just my own anecdotal reflection. So I'm wondering, how would you infuse it in your teaching? And then any thoughts about what I just said about religiosity versus spirituality?
That's a good question. One of the ways that I can answer it is with the families themselves, we didn't bring up religion and spirituality. They brought it up because it was such a strong, such a salient a resource for them. And from my experience in the classroom setting, when we're talking about culture and understanding clients and family systems better, I think if you address it from the perspective of that this is something that they use, that this is something that's important to them, and how can we support that? I think in that sense, I think that's one way to be able to approach it, to understand that it's something that's important to them. Therefore, it's important for us as clinicians to be comfortable ourselves with being able to talk about it.
I enjoyed the talk, and I've heard you present a little of this data that
Yes,
work on. But so this is maybe not is not within your study. I'm just curious. Now I'm thinking about it as you describe the findings. So hope, in your view, or at least in some of the qualitative discussions, you sort of are seeing that hope is a protective factor. And religiosity or spiritual practice and is associated with hope, or contributes to, you know, to this hopefulness.
Mhm.
So is it, do you feel like you could imagine implications from this study for what, I'm just thinking about intervention development, and not necessarily just within this population, but any population for, from what you heard from families, for ways that things that would enhance family and caregivers' hopefulness about their capacity, or about what the future holds for themselves or their family members, et cetera. You know, because it, yeah, I mean, what do you think about that?
It's interesting because one of the things that I was able to ask families was about hope a little bit more in terms of what we can do in the intervention to support hope, given that hope didn't change very much. And I don't think it changed very much because it was already very high to begin with,
Right.
which is, again, speaks to this culture. So I asked them, so what else can we do to help improve and increase your hope, or make it even stronger? And they said that they felt that we were already doing it. They talked about how some of the findings that we shared with them in terms of like how the illness, or how individuals with the illness tend to do better as they get older. So that kind of made them feel hopeful, knowing that in the future things will get better. Also, when we shared about how there are individuals with schizophrenia who are able to do well, who are succeeding, that also helped them in terms of seeing that this is a possibility for their family members. It may be something that they can hope for their family members. So they gave us other examples, but so getting their feedback was, I think, important. So it's something that we're looking into, being able to go back and incorporate some of these into the intervention. But hope and spirituality were already very strong
Right.
within these families.
Right.
Yeah. Yes.
You know, the thought that I had on hope, if you were to replicate the study here, let's say Mexican families here or Hispanic families here, but I sometimes think about the ecological context of where both the intervention is being offered and also the service system, and to what extent is the environment hostile or embracing of both the illness, the cultural population. You know, so it's a thought that I think about the receptions, for example, of most Mexican Americans here in New York City, right? Because they are truly a newer Hispanic entity in the Northeast, and certainly in New York. They're new to service delivery systems that have, by and large, have been more accustomed to treating other Hispanic groups. You know, the whole ecology of care and the whole contextual factors that oftentimes may really make a recipient of service more vulnerable. So it's just a thought as I sit here and I listen. If we were to compare, you know, Hispanics here with schizophrenia in our service systems here in the Northeast of New York versus LA, where there may be natural niches that indeed help to sustain the level of hope that you noted in your sample. It was just a thought.
And it would be interesting to explore that,
Yeah.
right? Maybe if they were to be with Mexicans here, perhaps they haven't been here that long, maybe they don't have those resources. Yeah, good point.
I'm wondering what you know about the families, or if you looked at differences within the families. For example, whether there's an extended family network here, the generation in this country, the density of the family, and whether that made any difference in your findings.
Well, I did ask about other sources of support that they may have, and those that had children, for instance, who were more involved in helping their sibling, for instance, since the majority of the caregivers were parents and mothers in particular. Those who had that extended support did experience less burden and so it did help them. But then there were also those families who had the families in support, or that who had those families in place, but those families weren't as supportive. Perhaps they contributed to burden, or they contributed to feelings of stigma that they had, because maybe these families weren't as aware about what caused the illness, or just aware about the illness itself. And there was more criticism that they as caregivers experienced, or clients maybe experienced from other family members, from extended family members, criticism and stigma. So I think that was interesting. Yeah. Yes.
So I have two questions. One is about most of the research suggests as communities acculturate, the outcomes get worse.
Mm-hmm.
So health outcomes get worse, obesity gets worse, asthma gets worse, mental health gets worse, etc. Do you find a difference in acculturation amongst your population? They also, except for African Americans, I understand, also become less religious.
Right, and we did look at acculturation. That was a measure that we examined. However, all the families were pretty much low acculturated, so there wasn't a lot of variability, which prevented us from being able to really make those kinds of comparisons. But I think if we had that sample that included those differences, we might be able to see differences in terms of the protective factors and perhaps even just the overall outcomes. Yeah.
Were the identified patients here first generation?
The majority were second generation.
Second, right, because it
Yes.
speaks to the
The
Dean's
families
point.
were first, yeah.
Families were first, that whole notion of the Latino paradox, right?
Right.
So that first arrival appears to be healthier
Right.
at all levels, from health
Right.
to mental health, and then second and third generations.
Right.
Yeah, right, that's
Does
the
it flip
criteria.
back and forth?
Huh?
Does it flip back and forth?
No,
No.
it doesn't. It gets
doesn't.
worse and
It
worse
keeps-
and worse.
Apparently, the Latino paradox keeps
The
getting worse
only,
and worse. Yeah.
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 The only difference is African Americans tend to be more, the religiosity tends to stay high, but not in. Okay, so can I go to my second question? So my second question, I think I've just seen the data, so I know that the mental health, the group of students here, it's our number 2, mental health is our number 2 most popular method. Child welfare is our first, family and children's services is our first, and mental health is our second. So with all your practice experience and this important research experience, what absolutely do we need to make sure we have in our curriculum?
That's a good question. I think it's important. I think when I was produced the quote from the Surgeon General, and looking at for social workers, practitioners, to look at what is healthy within a family system, within an individual, and try and work towards supporting that. Sometimes, I think especially with the medical model, we're kind of forced to look at what isn't healthy. That's kind of the way it works because of funding and all different reasons. But for us to, and I think naturally as social workers, we're kind of already following that, in that direction. But I think it's good for us to be reminded, especially when we have studies that show that including cultural factors and protective factors make a difference. So that could be another reason or another way to support that argument. And I think it's important for future social workers to be aware of that, and also to be aware of how to advocate for that within your agency or practice setting, which may not always be supportive of that for various reasons, but how you can advocate for that within your own setting.
So a strengths-based approach is
Yes.
basically.
Mm-hmm. Which I think we already do, as I said, as social workers. Yes.
The research tells us that for those with chronic mental health conditions, such as schizophrenia, that work is very therapeutic. That work tends to bind the ego and to improve social and family functioning. To what extent did you explore, would you be interested in exploring with this population, the variable of work as a therapeutic element?
And that is a very good question, because it was a concern that clients shared. And when I asked them about what they considered to be an important outcome, they mentioned work as being something that they strive for, that kind of would signify that they had, that they were part of society, that they were doing or aspiring for things that anybody would want. So it kind of would help them in various areas. So they very much talked about wanting to engage in work activities. So yes, it would be something that would be interesting to explore further.
So do you find that as a source of contention between family members and the patient? Because usually family members would expect the patient to go look for work or to be able to hold a job.
Right.
And when that doesn't happen, there's a lot of blaming. Is that what happened, or?
No, I wouldn't find that to be the case. For most families, especially after having gone through the intervention, they understood more about the illness, and perhaps that the behaviors that clients were exhibiting, their perhaps inability to keep a job, wasn't something that they were doing because they were lazy, which is something that some of the thoughts that families were having in the beginning. So they're not working because, he's not working because he's lazy. So they were understanding, no, it could be part of their illness, some of the symptoms that they're experiencing. So there was more understanding and more acceptance. And in general, studies have found that low acculturated families tend to be more accepting of the individual with the illness. Yeah. So there's less blame.
Right.
And that itself can be a protective factor.
Right.
Yeah.
So I assume that they get benefits, the patients?
Most of them were getting, yes.
Because what about the undocumented immigrants? So you don't,
Right.
did you have them in your sample?
I did interview someone who shared that he was experiencing challenges due to his undocumented status and how he wanted to work. But he couldn't because of that, and because of his illness itself. It was challenging, but it made it even more challenging because of his status.
You had said that people with substance abuse were hospitalized more frequently, which is in all the literature as well. But I was wondering if you looked at substance abuse and hope, because the people with substance abuse kept getting hospitalized, and I wondered if that illness severity that comes from being hospitalized over and over again, if that influenced the family's level of hope. And then also substance abuse, there can be more blame put on individuals as opposed to illness.
Yeah.
So I was wondering if you looked at it, or looked at it here in the qualitative part, maybe substance abuse and hope.
Right, and that's something that I'm in the process of analyzing.
Oh, great.
So yes, I think that because definitely those were the families that were the most challenged, and those were the ones who were experiencing more burden. And those were the ones who, they still expressed a lot of hope, and their spirituality was very important to them. But they certainly did, they talked about how they were more challenged in their hopefulness and in their spirituality. So yes.
Okay.
Yeah.
One question I have, this is my last question, okay. So your teaching, could you tell us something about your teaching? How do you envision your teaching? It's kind of like a follow-up, but how do you see your teaching here, and what would you do in your teaching process with students? Just anything you can just share about your thoughts about teaching. I don't know if you're currently teaching now, I don't remember, but just anything about your teaching. How do you envision it here in an urban context, East Harlem?
And somewhat similar to LA, because we are also in an urban context.
Yes.
And it is in South
That's
Central
true.
LA.
I stand corrected,
Yeah.
yes.
And a lot of, we have a lot of students of color, even though
Yes.
it's a private university.
Right.
So a lot of them come from like the community
Yes.
where the university is at.
Sure.
But just similar to the experiences that I've had, that I've been able to share about my practice experiences, and they just, I can tell how much they appreciate that and value that, how many questions, I would get afterwards. And so that's something that I see myself being able to continue to incorporate into my teaching in terms of, and also in terms of what I would be interested in teaching. It would be clinical courses and interested in perhaps in the first year courses as well as the advanced courses, practice courses.
Thank you. Any other questions? If not, we'll end, and make sure you hand in your vows, please. If you have them now, we'll take them. And thank you so much for coming.